Hello, everybody. My name is Ali Ghanem. I am based in London, UK, and I'm very happy to be talking to all of you about my experience and other people's experience of this new technology. Now, I am assuming that the audio and video is working for all of you. I cannot see you, but I hope that you can see me. Please communicate to the facilitator if there was any problem, but I reassure you that this webinar is going to be recorded, so hopefully you will be able to refer to it later on if you cannot catch me here. So this webinar about a technology that is not relatively old. It is new in aesthetic medicine. It's been available for the last 2 to 3 decades. However, there has been a lot of evolution and improvement from both scientific and in engineering way to make it available for us at the bedside and in our clinics. The technology is called GVR, or jet volumetric remodeling. And in this talk, I'm going to go through and introduce the technology for you. And I'm going to mention some elements of the regulations and the quality assurance that has been put into creating this technology into an aesthetic and regenerative medicine tool. And finally, I will touch base on some of the clinical indications and protocols. As I said, I'm a plastic surgeon based in London. I am a senior lecturer at Queen Mary University of London, and I lead the Master in Aesthetic Medicine in that university. I am the founder and director of the Academy of Aesthetic Regenerative Medicine in London, and I practice at the Cranley Clinic. And here are some of my disclosures. I am a key opinion leader to a few technologies, including Enerjet, that are involved in regenerative medicine. I don't have any shareholding, and I only get paid for my time so that I keep my objectivity as much as I will be able to communicate it to you. So in relation of the technology, you can think of this technology not only as a tool to combat the aging process, but also a tool to combat some of our medical conditions, such as scars, hypertrophic, or even keloid, some of the problems that happen during our evolution during teenage, like stria and stretch marks, and some of other problems such as acne, etc. I would like, however, to tell you, probably all of you know that in the aging process, we have 3 main problems that is affecting us. The first one, which is a superficial problem, it's the sun damage. Sun damage can go all the way through the dermal layers and can cause significant loss of elastin and collagen. It is estimated that we lose around 1% of our total collagen every year anyway. Of course, if we are in climates where there is a lot of sun damage, this can become more accelerated. Second thing is the attenuation of the suspensory ligament because of the muscular animation, because of gravity, all these others, and also finally volume loss affecting all the cardinal layers of the human being, from the bone all the way to the epidermis. In order to restore that, we have to engage with these 3 elements. We have to address the collagen and sun damage by collagenesis and the resurfacing, for example, using energy-based devices like microneedling or energy-based microneedling or CO2, as well as we have to deal with the volume loss, and we have to kind of address that by restoration of the volume by means of camouflage, such as using synthetic fillers, hyaluronic acid, polylactic acid, polycarbolactone, all these different biocompatible fillers, or we might have to sometimes put implants or sometimes use fat grafts and autologous interventions. And as you could see, there isn't a one solution that fits all. Then we will have to think about suspensory ligament structure and try to think of a surgical intervention or thread lifts or any such intervention that will address the laxity of the skin that cannot be addressed by collagen and superficial layers restoration and a volume restoration. So all these things has caveats. From one end, we are increasing the numbers of interventions that we are putting the skin through. And from the other end, for example, if we use low laser, we are limited for those patients who have, for example, susceptibility to acne scarring, or those who have Fitzpatrick type 5 and 6, because we cannot do energy-based devices for them for the risk of hyperpigmentation. Here, jet volumetric remodeling comes as a solution that can both address the volume loss in the dermis and also address the laxity by new collagenesis without the side effect of energy, because we are using physics and mechanical energy only. Now, I'm a plastic surgeon and I have been very much interested in wound healing and regenerative medicine, and I've spent a lot of my time teaching on our sister course in the master in burn care, and I have been involved in burn in my public time. So some of you who are involved in burns will kind of like remember when somebody would have partial thickness burn affecting, let us say, an element of the face. When the patient successfully end up healing, you will realize that the burned areas looks much better and more rejuvenated and regenerated than the areas that has not been burned. The reason why is with any partial thickness injury, the body tried to repair, and in the context of repair, it regenerates, especially if the key deep nexial tissues such as the sweat glands or the hair follicles have not been damaged. Now, this is the cardinal principle in which we use fractionated or partial thickness controlled injury, such as CO2 laser resurfacing, ablative or non-ablative. We are relying on the body's own potential to regenerate by introducing a controlled injury. This controlled injury can come from all sorts of offenders. It could be the light, such as the laser, or it could be the electromagnetic spectrum, such as radio frequency. It could be the focused ultrasound, such as in HIFU, etc. But we are using controlled injury to get the body to try to repair this injury and then have the desirable outcome of regeneration. Now, if you think of this injury and why fractionated laser is better, for example, than fully ablative laser, it's all about the dose of this injury. So when we use a fractionated laser, we are less likely to have side effects compared to fully ablative lasers. Why? Because the fractionation allow us to control and reduce the scale of this injury for the body to overcome the threshold of scarring into regeneration. Now, something amazing about the human body that we still are investigating, that we are different from the salamander. The salamander, for example, if you amputate a toe or even a whole foot, they are fully able to regenerate. Now, we were able to do that. You can imagine, for example, when I was a fertilized egg and I became, for example, an 8-cell embryo. If you went then to me at the 8-cell stage and destroyed not only 1, 2 of these totipotent stem cells, and I have now lost 25% of my total body mass, these 6 remaining stem cells are able to recode me completely and I will grow as a full human being without any scars. You can imagine how the, identical twins happen. The fertilized egg is divided into two, and then each one of them will carry on and become a total multi-organism. Now, at some stage in the embryo, that ability to regenerate all become less and less. So, for example, if we go to a kind of like 1 month embryo and create a damage, which is around 1% of the embryo's total mass, they will be able to regenerate that, no problem. But later in the embryologic and fetal development, the threshold becomes roughly 1 centimeter. Now, a 1 centimeter full thickness burn on my dorsum of the hand is definitely going to leave a scar. That does not happen in fetal wound healing, but later on that injury become only confined to the epidermis. So epidermal sloughing or epidermolysis is fully regeneratable, but dermal injury failed to do so unless we are under a threshold. Now, all of you know this threshold, although we don't kind of like think about it. When we like injure the dermis, for example, when we take bloods using a 21 gauge needle or 25 gauge needle, we are creating a full thickness dermal injury, but that is fully regeneratable. So if you can imagine microneedling, all this damage that we are creating to the dermis is fully regenerable. So GVR or jet volumetric remodeling utilize these principles of regeneration by creating atomic bombs on a microscopic level in the dermis. So how does this work? We don't use any heat. We don't excite the melanocytes. So it's suitable for all skin types. There is no burns and there is no relationship to the sun. We can reach all the way to the subcutaneous tissue, to the fat if necessary, and we are in total control of the energy and the level where we want to put this energy within the skin. It's simple. We are able to uniformly apply this atomic bomb on a microscopic level, and we can reach up to 6 millimeters. Look at this jet. It's 150 meters per second. We can reach all the way to the bone with it if we want to, but we usually don't. We just confine ourselves with the superficial dermis or the deep dermis. It's completely needle-free, and the entry point is similar to something like a 25 gauge needle, is around 0.2 millimeter, 200 micron entry point, and it's a very unique way to introduce anything we want into the dermis with a tiny liquid as small as 50 microliter. So look at these two images. The one on your right-hand side is a small leaf-like blue. That's what we do when we actually try to inject the dermis using a 1 cc syringe and a 30 gauge needle, for example. Look on the left, that is the atomic bomb that I'm talking about. It's 100 times more powerful, however, very homogeneous, and it is around, maybe a cubic centimeter plus and minus depending on the characteristics of the dermis. Now, if you think of these parameters, we have now a new paradigm of kinetic intervention that is creating small microscopic injury to the dermal structures like elastin and collagen, and as these try to repair themselves microscopically, we are having true regeneration and reorganization of the dermal regeneration towards all the clinical indications that I'm going to tell you about. So let's look at some of animation to show you how this works. So when we are introducing this bullet of liquid that I'm going to discuss with you, it goes and it spreads through the dermis. It makes it like a Swiss cheese with holes, that will be filled with the liquid that we introduce. Now, normally when this happens, and if we put only sodium chloride, all these gaps will be then collapsing. And you could see here in the video how the bullet will enter the dermis and then homogeneously creating this Swiss cheese multi-hole area. So in order to prevent the collapse of these holes, we then are able to put a little bit of hyaluronic acid to babysit these holes, pending the proliferative and the remodeling stage of wound healing, where all these holes will be filled with collagen, leading to significant improvement in the dermis thickness or addressing the problems such as striae or acne scars, etc. The beauty of this particular machine in my hand is that I don't need to refer to a quick reference guide. All the protocols of all the available indications are integrated within the software that uses the machine, and we have 4 main platforms. One of them is related to dermal thickening, one is related to kinetic lift, and one is related to scar remodeling. There is also one general use that is left for all sorts of things like hyperhidrosis or having new indications that is really the limit of which is the imagination of the practitioner. So with all of these different aspects, when we click on a particular area, we will then be ending up with a step-by-step advice towards the very end of the treatment. It's so easy and it's so fluid. You can imagine, for example, sometimes when you use CO2 laser, we have to do different setting on the face versus the neck, because the embryonic origin of the face skin is from the neural crest, where the neck and the rest of the body is from the ectoderm, and the number of stromal vascular fraction density in the face is completely different compared to the rest of the body, and the healing is different. But here, when we use the kinetic injury, we are not limited by the area of the body. We can use the same parameters. The only difference is changing the size of the bullet and the strength of penetration depending on the thickness of the skin. This particular product and the new version of it, 2.0, has been through all the regulatory elements from North America to Japan, including CE marking, etc. And you can refer to this from the company's website. Let us talk a little bit about how we use the treatment, these 4 treatment groups. For example, when we're talking about kinetic lifting, we are here trying to create these atomic pumps. Let us imagine a 10 centimeter vector along the mid face. Now, if we introduce one atomic pump along this 10 centimeter, that will lead to the proliferative and the remodeling stage of wound healing, and the myofibroblast will kick in later. The contraction that will happen will turn that 10 centimeter after 6 weeks into, let us say, 9.5 centimeter. If we repeat the treatments 2 or 3 times, we can get that 10 centimeter to shrink by around 15 to 30%. That's what I do in a facelift at the skin level, of course, or the SMAS level. I am trying to shrink the distance, i.e. the skin axis, and maybe I will get 1 centimeter, around 10% of the total surface area excised at the end of the procedure. So here we are guiding the skin in vivo remodeling in order to create that tightness. Accordingly, you can use that tightness for gentle brow lift, for mid face lift, for jawline contouring, and this is very, very popular treatment in the Far East and South America at the moment. I'm trying to develop it here in Europe too. Acne scarring, you can imagine, for example, box scar or ice pick scars of acne. Every time you introduce this atomic bomb at the bottom of the scar, we are leading to significant, very precise neocollagenesis that will address these scars precisely. And I will show you some of the clinical pictures that are extremely remarkable. In relation to dermal thickness, we are losing the collagen, as I said, periorbital area, everywhere, hands, face, and you can guide that loss and replace it and regenerate it. And in the pipeline, although has been established now, hyperhidrosis of the palms without the need of a wrist block, submental fat lipolysis with all these new emerging medications such as Kybella or Bicara, you can use this as also transdermal drug delivery, but you must understand that this is not a substitute to a needle or a syringe. It is a complete new paradigm of kinetic injury with jet volumetric remodeling. So you could see here the histology section of this Swiss cheese that I told you about. All these white gaps within this dermis has been now filled with the babysitter, which is the hyaluronic acid here. And then as the body responds to this microtrauma by the fibroblasts and the myofibroblasts and production of collagen, all these white holes is going to become like pink. And the epidermis, as you could see here, is completely intact and unchallenged, which means hypopigmentation is not an issue. So this is here, you could see the control. We can go from 1.6 to 3 millimeters to 4 millimeters, depending on the characteristics of the skin. And this is here a dyed product that show us the three-dimensional spread of this explosion, 0.4 centimeter in the thickness and up to 1 centimeter in the 2D dimension. Here you could see the technology has been extremely appraised by ultrasound, by histology, to show these characteristics and ensure total control of the dermal remodeling. Now, this is the most important slide in all this lecture, showing you a true histological evaluation of different areas: periorbital, neckline, neck, lip, nasolabial folds, and the forehead after a protocol of a 3 treatment. And you could see here the winner was the periorbital area with up to 300% increase in the dermal thickness. The poorest was the neckline, because of course we cannot splint the patient's neck for 3 months, and the area is highly mobile, but still an impressive 150% improvement in the thickness of the dermis there, which makes this probably the single most effective treatment for horizontal lines in the neck, refractory to all sorts of surgical and energy-based intervention. Now, this is, I would wish to have showed you a case here, but I kind of kept this case for you to show you the challenge that we are able to overcome using this technology. So this patient is a very young patient. She doesn't have really a lot of volume loss, but she was not happy about the kind of nasolabial fold and the parallel cheek lines that appear when she smiles. Now, these lines cannot be treated by Botox, because if you treat her around this area with toxin, she's likely to have infusion that is going to affect her smile. So by trying to subsize the attachment of the zygomaticus major and minor muscle from the skin and build the collagen in between the skin and the muscle, we are able to hide these. And this is a unique indication among other. Of course, all the static lines in the face and all the thickness of the skin can be addressed easily, but I chose this case to show you the complexity and the versatility of this condition. This is like the video showing you how this is moving on, and you could see after we inject, we have this little papule. We have this little papule which look white because the pressurized fluid has pushed away the dermal plexus, and we have a vasoconstriction will last for around 40 to 50 minutes, after which the fluid will go away. Only the hyaluronic acid, for example, here we use a 2.5 milligram per ml solution. So only the hyaluronic acid will be left in these Swiss cheese holes. And after 6 weeks, we can repeat the treatment and repeat it again. This is how the lady will look immediately after treatment. And you could see here how she will look 24 hours after, 48 hours, all these little kind of like entry points has completely resolved. This is here another example of this lovely lady where we are using kinetic lift on her jawline as well as the horizontal necklines. And you could see here following the treatment, there was a little bit of ecchymosis on the neck, but otherwise 24 hours later, she doesn't show any other side effect of the treatment. And unlike the first lady, you cannot see even the entry point. The kinetic lift is a subtle one. We are not talking about a facelift, but it is a significant one. The patient, you could see here the degree of brow elevation that you are able to achieve. I don't think I will be needing more than that, even if I am intervening surgically. Also, the degree of malar kind of lift, which is very impressive, jawline improvement. Sometimes the patient is very happy with this without really the need for any surgical or thread lift. You could see here the improvement after two treatments with horizontal necklines. You could see here the improvement after 3 treatments with acne scarring. You can put triamcinolone or 5-FU for hypertrophic and keloid scars. And also the stria is very exciting treatment as well. This is an example of the improvement of cheek lines and the kinetic lift of the jawline. And of course, the décolletage and all the collagen loss associated with sun exposure can be addressed very well here too. There is a very rich list of publications and peer-reviewed articles associated with this technology, and I recommend you to refer to it. And you could see here some of the leading regenerative gurus in the world, Professor Yoshimura, Professor Kasuto, and the level of peer review that this technology has been subjected to so far. So that's all from me really in relation of an introduction of this technology and the exciting spectrum and horizon of its utilization. I have been using this technology since 8 months now, and I am now around the time where I see really amazing results that I'm not able to achieve by normal core needle subcision or CO2 laser on acne scars. I have been super impressed with the kinetic lift with a few patients with kind of Northern European skin textures, especially around the brow lift. I really don't like the kind of clown look of high elevation of the brows, and I really don't like to do that surgically. So I'm very, very happy with the mild degree of kinetic lift that I'm able to achieve in the upper face too. And the dermal thickness, especially at the dorsum of the hand, the periorbital area, and in generally the neck area, has been a very interesting highlight in my own practice. I will stop and I will take some questions from you. You can type, I believe you can type your question and I will be able to see them. And I'm very happy to receive any question you may have. Coordinators, is there any question? So what's the experience with keloid scar? Very nice question. Thank you, Mahesh. So the keloid scar, I have put patients under general anesthesia sometimes to inject them for their pre-sternal keloids. And we can go like all the way until excision and radiotherapy, which is very, very invasive intervention. Now, I have treated a couple of patients with keloid scar, and I can tell you that the homogeneity of intralesional injection that can be achieved with very, very minimal discomfort has been a very useful tool in my hands. I haven't yet had a lot of patients that I have treated apart from these couple, but so far I am very happy with the as I said, homogeneity and the lack of pain, and I'm using it with triamcinolone and 5-FU, and I can report on my experience in a couple of more years, I think. But there is already a protocol for keloid scars, and some of my colleagues in South America and the Middle East have used it very successfully that way. Protocol for white stitch mark, yes. So as we said, Mahesh, that there is a dermal scar with the stretch mark. So here the same protocol of dermal thickening is very effective in creating collagenesis, and I have treated few stretch marks. 2 treatments, I can see improvements. So the people who have darker skin, probably more challenging because of the kind of pigmentation element and the difficulty to get a perfect tone. But in the Anglo-Saxon or in the Mediterranean skin type like me, it is a very, very useful and effective treatment. But you will get improvement even in darker skin type. Protocol for white skin. What are the side effects and complications? I had 1 complication out of over 100 patients treated so far, which somehow she had a kind of like a spider nevus in one of the entry point. I'm not sure whether this has been kind of like something that she had before. We looked at the pictures before of a little bit of telangiectasia that I treated with radio frequency, you know, kind of at the office. That was the only problem, and as I told you, I have treated my own nurse, and she developed a little bit of a bruise on the neck. One of my patients reported that the entry point lingered for about 3 days, but otherwise these are the only complications associated. There is no kind of possibility of having a vascular event with this because you are really so precise in the intradermal domain, and even if you kind of like try to enter an artery with this, it's not possible because you saw how dispersed the bullet will happen, and that will go all over 1 centimeter, so you will have a insignificant droplets after the entry of the epidermis to not be able to create a vascular accident. Have you tried comparing the results of non-cross-linked versus cross-linked filler for kinetic lift in terms of duration or results of quality of life? I have to say that our Far Eastern colleagues use hypertonic solutions such as you know, high concentrated dextrose and a cross-linked, but I don't believe personally that in my hands I have used Juvederm, I have used like uncross-linked products such as Profilo, and in my hands and in my intuitive understanding of the mechanism, I think the cross-linked will babysit the holds slightly longer than the cross-linked HA, but to be honest with you, the mechanism is so powerful at the repair and regeneration that I don't believe it's kind of, it will make a difference. It is the dispersion, what I would say the atomic bomb effect, and the micro fracture of the collagen and elastin fibers with their remodeling is what is giving us the results, rather than the degree of cross-linkage of the solution. Can you please repeat the number of sessions required at the interval between the 2 sessions? Also, what would you be in the solution used to acne atrophic scars? Okay, so here for the bullet and the dispersion to be optimized, there are lots and lots of mathematical and physical optimization that went through before we have this product. So at the moment, a 2 to 2.5, sometimes in South America, they try to use like 2.8 or even 3 milligram per ml solution concentration of HA. I believe the more viscous the tissue, probably we will have difficulty of it penetrating the epidermis and the dermis. So the 2 to 2.5 milligram per ml has been optimized for the mechanical characteristics of the, what I would call it, the parcel or the volume that is injected. So accordingly, we use a sodium chloride solution with any diluent that you would want, for example, triamcinolone, with any concentration. Now, for the viscous ones, we would recommend 2 to 2.5 milligram per ml of HA, regardless of the degree of its cross-linkage. The number of sessions, I think 1 session is probably associated with improvement anyway. I have seen that, especially in hypertrophic scars, I could see maybe 30 to 40% improvement of the depth of the scar after a single treatment. But it really will depend on the age of the patient, maybe like the degree of the scar and other factors. But on average, 2 to 3 treatments is necessary, and the separation is very biological. We are dealing with the wound healing, and as you know, the inflammatory stage is between 48 hours to 96 hours, so around like 2 to 4 days, and then the proliferative stage is between 3 to 6 weeks, and after 3 weeks we enter the remodeling stage. So from that end, I wouldn't recommend a second treatment or a treatment interval which is shorter than a month, but there is no limit to how many sessions you can repeat them. Of course, you don't want to make the patient look like silly by hypertrophic, because this is a very powerful treatment. You can really make their dermis go thickened, and creating from a valley, you can create a hill. So here you have to use your clinical judgment and wait and see the response. 4 to 6 weeks later, you can repeat the treatment. On average, 2 to 3 treatments are adequate to address all the problems I shared with you. As it's used for all skin type, then how it's not giving good results in darker skin? I'm only talking about the stria in darker skin that we might not be able to have as homogeneous results as we will have in the Northern European Anglo-Saxons, because the color here of the stria in the kind of darker skin is related to the distribution of melanocytes as well as the dermal injury. So, but in an Anglo-Saxon, the difference in hue between the stretch mark and the surrounding skin is really not as contrasted, because the normal skin of a Fitzpatrick type 1 and 2 is almost ivory. It's almost the same kind of like color of the scar itself. So the restoration of the dermal scar is going to lead to better hue contrast, where in the Afro-Caribbean, for example, we see improvement but I will not be able to tell you you will see complete homogeneous field after 2 or 3 treatments, because the complexity of pigmentation and the variance in the color shades between kind of like the scar, the dermal scar, and the epidermis lying above it. Now, I think the earlier you treat these, the more likely you will have a more homogeneous results. But for other conditions such as hypertrophic scars or acne scars, I have one of my patients who is really Fitzpatrick type 6, and I treated him for acne scars, and I have remarkable results in him with the evenness of his scars. But I mentioned the difference is in the single indication of stria or stretch mark. Do you feel cross-linked HA will reduce treatment sessions? It is the impression of the collective kind of experts that yes, using cross-linked might reduce the number of sessions. However, as I told you, we are not using the HA but as a babysitter, and any uncross-linked HA is likely to stay around for at least 8 to 12 weeks. When you use kind of like a hydrating or very uncross-linked for very superficial rhytids, you will see the product effective to holding the small fine lines for up to kind of 8 or 12 weeks. And all we need here is to splint these holes until the fibroblasts are able to produce enough collagen. So I think even uncross-linked HA, and some of my colleagues, senior users of the technology, use only uncross-linked HA, because like here we are really using the molecule as a babysitter. So I'm not sure. It would be very interesting study that would require a huge logistical mobilization to follow up. We need maybe 200 patients in each arm, and in cosmetic interventions, large, high-powered randomized controlled trials are extremely expensive, very difficult to organize because of the nature of aesthetic medicine. Please share your experience of treating areas other than the face. Any experience of treating the acne scars in the dorsal skin? Do you mean like in the face? Yes, I have treated acne scars on the back, for example. Very impressive results. My senior partner at the Cranny Clinic is Professor Nick Lowe, who probably you know him by introducing Botox to the world. He was on the first randomized controlled trial that gave botulinum toxin its FDA approval in the United States, and he is one of the gurus of acne scar treatment. And we had a couple of patients with acne scars on the back that we tried all sorts of subcision and some kind of like collagen stimulating agent in with CO2 laser, and they were really refractory to all that, and an amazing improvement using the Enerjet device. I also have used it like when I do hair restoration surgery. I use it with lidocaine to improve like my ring block, because patients complain about the ring block there. I have used it also in like very tiny little basal cell carcinoma excision scars leading to unequal nostrils, and I have managed to kind of equalize the nose. As I told you, I'm trying to kind of coin a new concept, which is in vivo dermal remodeling, and we are using the wound healing and the matrix generation to guide the tissue. It is really the imagination is the limit of this treatment. How is it better than CO2 if the downtime is not considered? So if you can think of CO2 and let us say ice pick scars, you are not introducing a single beam that goes at the bottom of that ice pick scar. The beam is far less than the dimension of the ice pick scar. With CO2 laser, you are fractionating a field and hoping that your columnization of these light kind of entry points are going to help in a global collagen production that will eventually help in evening out the scars. If you are talking about CO2 ablative, then yes, you are destroying everything and asking the hair follicles and the adnexia stem cells to kind of like resurface that area. But then you are talking about significant morbidity and significant limitation of skin type. With here, you are targeting that particular depth of the valley of the ice pick or the box scar with as many bullets as you want to make them even. You can be so targeted that you can treat only these scars and be much gentler around the other areas. No energy-based device is as targeted as this. And even though you might think, okay, I'm going to use a plasma pen to address these ice pick scars, you are then limited with the depth at which you will ablate. Here, you cannot be limited. You can stack the treatment and make it like, you know, you can do 2 or 3 shots at different energy to completely address the scar from the subcutaneous tissue, if necessary, all the way to the epidermis. So there is no such high specificity of treatment in addressing dermal conditions such as this technology. Have you tried it for melasma by incorporation other mesotherapy cocktails? I haven't. I would be very interested to see if this is interesting, and I actually love to use regenerative medicine such as platelet-rich plasma and nanofat and, you know, kind of micrograft. And the team at the company are trying their best to create a barrier now that will allow us to use the biological products without cross-contamination. But for mesotherapy, this is the ideal treatment for mesotherapy. But I'm a plastic surgeon. I spend most of my time doing rhinoplasties and facelifts and blepharoplasty. So I don't use it in my mesotherapy, but surely if I was a dermatologist or if I was a aesthetic practitioner, I would use this immediately for my mesotherapy, and I will put anything I'm going to use in it. Okay, where are we now? Have you tried PRP treatment? I have just answered that. It is absolutely essential that we try to limit cross-contamination here. This device, as you could see, this is the powerful handpiece of the Enerjet, and as you could see, this size here is a metal. This size here is plastic, and this is where the product will be. But the product then will connect to this metal side, and there is a little pistol tip that will push the plunger. Now, there is a theoretical potential for that plunger to have some contact with the product. Therefore, at this stage, we cannot autoclave the whole handpiece, and we are trying to design a nozzle that will ensure total prion, viral, and bacterial isolation of the nozzle from the handpiece to enable us to move into the biology. Off-label, I don't know. Some people told me in some conferences that they are using it there. I would be a little bit anxious because of this theoretical cross-contamination, but the concept is yes. However, the technology now is awaiting this modification for biological material. Probably within 6 to 12 months, we will be able to extend into the biological domain. Those were all the questions. Thanks for the wonderful presentation. Oh, thank you. It was my pleasure, and I hope that the audience has enjoyed this and learned about something which is so pioneering and so forward that I think within a few years, for those who can afford the technology, we will see patients like not using dermal filler, moving into dermal thickening, and all sorts of in vivo dermal and tissue regeneration, and the technology here allow us to start very safely and effectively offering this to our patients right here and right now. Thank you all very much. It was a pleasure to be with you. Look me up, Ali Ghanem, on Google's, and I'm very happy to receive further questions. Might be a little bit tardy. I'm a little bit kind of like busy, but I will try my best to answer all your questions, or you can go to our coordinators and you can also refer to this recorded version of the lecture at your convenient time. All the best for now and good luck.